Thank you so much, Dr. Goldman, for a wonderful presentation. Just awe-inspiring and so exciting for those of us that see people with MS every day, those of you who are living with MS every day, and those people who have yet to be identified as having MS. There's lots of hope and lots of reason for excitement with work like this, and we thank you for starting off with those songbirds. So thank you so much.
Thank you.
What we'll ask right now is if there are members of the audience who have their question cards ready. We're going to take the first set of questions for Dr. Goldman, and we'll ask in the meantime if our panel members could join us up here on the stage. Dr. Goldman, I'll give you our first question, and that is, a few years ago, stem cell therapy was an option, but only for extreme cases. What about today? Can this therapy be an option for the less extreme cases and or the general population with MS?
So, and as I mentioned, we're looking at this initially as a potential treatment strategy for secondary progressive MS, perhaps for primary progressive as well. But by definition, those are more significant cases in terms of the degree of disability. And so that we'll be starting out with patients with those more severe forms of the illness, in part because no one ever wants to use what's fundamentally an experimental therapy on anybody who are really functionally intact, so that it becomes controversial in a variety of fields, not just neurologic therapeutics, how early to treat, because it's almost always the case that the earlier the treat, the better. But the flip side of that is that the variability in the disease course is such that lots of patients with relatively early stage MS will not have significant progression, will in many cases not ever get to the point of chronic progression. And so do we really want to chance what's effectively an experimental strategy, at least at this point, in those patients who may not need it and who may not significantly benefit? Because all of these things have risks, and it's not to overplay those risks, but nonetheless, we think twice about going into patients unless they have a really significant disability. And at that point, the cost-benefit argument becomes that obviously we're hoping to provide much more benefit to those patients at an acceptable risk level. But in patients who don't have such severe disability, again, does the relatively small increment of benefit justify the risk? So at least to start things out, we'd be going to reasonably significant cases of chronic progressive MS, not so impaired as to suggest that they don't have an underlying axonal complement that is still there to remyelinate. So that is something to keep in mind here, that this is a strategy that will only work in those patients where the underlying axonal loss has not been that significant. Because by the time an individual has lost too many neurons, has lost too much in the way of the underlying axons, then there's nothing left to remyelinate or to support. And so because of that, we're looking at kind of the intermediate stages, if you will, in terms of disability and progression for patients with secondary progressive MS.
Great. A couple more questions directly for you. Does the stem cell process do anything to regrow the damaged nerves as it does the damaged myelin?
Yeah, so that's a great question. And we don't really know. So we are assuming, frankly, that there will be significant beneficial effects on the underlying axons that are provided not just by the remyelination, but by the presence of the oligodendrocytes and their engagement with those axons. Now, whether that will result in regrowth of axons from neurons that have already been damaged, or whether that will simply stabilize and support those axons that are undamaged, we don't know. That's an experimental question that, frankly, we still haven't even been able to define very well in animals. I would expect that we'll be able to get that answer in the human trial, just as at the same time we're still looking in the animal models to try to define that as well.
So I have a couple of questions, and I'm going to kind of try to put them all together. And the question really is, if we're regenerating myelin with this process, is there anything to stop or prevent that myelin from being broken down and the process continuing?
Yeah. So again, another good question. So at least in the trial, what we're going to do to essentially get around that issue is to immunosuppress the patients. Patients will be on central immunosuppression. Now, many of these patients, of course, are already. Of course, it is, as many of you here know, controversial in secondary progressive MS whether to maintain patients on any sort of immunosuppressive agent or not. There's very little demonstrated efficacy data there once a person has stopped having relapses and gone to the secondary progressive phase. Nonetheless, many patients with secondary progressive are maintained on some degree of immunosuppression. For this trial, we expect to maintain that immunosuppression, or as the case may be, switch it over to a specific immunosuppression regimen that is used typically in transplant patients. And we'll maintain that for at least a half a year. At that point, we are still debating, and still a question going back and forth, both within our group and the FDA, in terms of whether or not beyond 6 months, whether to maintain patients on immunosuppression, or to switch to milder immunosuppressives, or to take patients off altogether. And frankly, that's a decision that still hasn't been made. There are pluses and minuses, pros and cons for each one of those strategies. We don't know what will happen in a chronic progressive MS case, somebody who has been stable without relapses for many years, we hope. We'll have an exclusion criteria that no one will be accepted into the trial who's had a relapse within the year prior. So if we are dealing with patients who have not had recent relapses and then are putting in new cells, will they be immunogenic? And then it may be different depending upon whether we're using cells taken from fetal tissue. These are allografts. It's not the person's own cells. It's literally the cells of another individual. Will they be immunogenic? Will they be essentially susceptible to MS attack? Or will it be different when at some point in the future when we go to iPS cells and potentially do these autologous grafts, which have the advantage that the patient doesn't have to be immunosuppressed because they're not going to reject those cells. On the other hand, if there's any, if you will, latent MS, in other words, T-cell clones that are still in those patients that might attack that patient's own oligodendrocytes, well, gee whiz, now that patient now has his or her own oligodendrocytes again. So will that induce an MS flare? These are all questions we don't know.
Thank you. We'll give you a break for just a minute while I introduce the panel, and we do have some more questions for you as we go through. So to introduce our panel, and as I mentioned, their bios are all listed in your booklets. From the far end of the table, which is your right, Dr. Antati. Next to him, Dr. Bernard. Next to her, Dr. Susan Rubin. Then Dr. Dan Wynn, as well as Dr. Goldman, and finally, Dr. Matthew McCoy. And I would like to thank all of you for, again, volunteering your time to help us answer some of these questions. I think I'll start all the way at the end with Dr. Antati, and one question is a flu shot recommended?
Flu shot is recommended for everybody. Patient with MS should have flu shot because the flu can be, the fever and the symptom associated with the flu can cause the patient to be feeling worse. Sometimes some people even feel that there is a relapse associated with the bad flu, but that's still controversial. The patient who are on immunosuppression therapy, obviously they need to not take live flu vaccination. Basically, they need to take the shot, not the mist. Otherwise, there is no contraindication for flu shot in patient with MS.
Great, thank you. So moving on, we'll go with Dr. Bernard for the next question. I'm a young 69. Is there an age at which the MS medication should be discontinued because they're no longer effective? Should I expect to continue on them for the rest of my life?
Is this where I can stand on my soapbox?
Sure.
Am I allowed at this point? So I think that's a really good question, and to get at that from a different direction, I think we're getting a little pressure from insurance companies exactly about that. Is there a need to continue on these therapies? My short answer is everybody should be really looked at in an individual way. We look at each of you, look at how your MS disease is doing, look at your general health, and your MS neurologist really should work with you to make a decision about what's the best treatment for you at that moment with your MS. So it may be a different answer 10 years previously, a different answer right now, but our general rule, I think everyone at this table would say, absolutely keep going, and we will work with you to figure out what's the right therapy for you right now.
Great. Another question, this one we'll give to Dr. Rubin. What can you tell us about emerging new therapies for other forms of MS?
So, you know, there is a lot of research going on and a lot of new therapies coming down the pike in the near future. I often say to patients, while there's never a good time to have multiple sclerosis, there's never been a better time if you have to have multiple sclerosis, because there's just so much research and so many new medications available now compared to just 10 years ago, compared to just 2 years ago, and there are so many more that are getting ready to be approved in the very near future. I think the next medication that's probably going to be approved is a medication called Lemtrada that is scheduled to be evaluated or a decision made by the FDA probably by the end of this year. And that's a medication that's actually given, I believe it's once a year. Actually, the study's only done 2 shots a year apart, and then, or 2 doses a year apart. And we don't even know whether patients will need further doses down the road. So that's going to be a very exciting development. And then there are a number of other drugs that are in trial that are variations on some of the medications that are already out, as well as new mechanisms of action that will hopefully get approved in the next year or two. So there are a lot of exciting medications available. There are even drugs that are looking at remyelination from a medication standpoint as well.
Great, thank you. Dr. Nguyen, I know that you have attended the ECTRIMS committee meetings, the European Committee for Research and Treatment in MS meetings, and one of the discussion topics there that continues on is the CCSVI discussion, and the question from the audience is, can CCSVI finally be dismissed?
Short answer, yes.
Would you like to expound on that, Dr. Nguyen?
At the risk of being torched on the internet, I'd rather not say too much more about it, but you know, one area the National MS Society, the Canadian MS Society, the European MS Societies has really been a leader, is helping us look into different potential strategies for treating multiple sclerosis. Just as an example, you know, those people at the booth from the drug companies, do they really have the cures? They're just hiding them from us? You know, or they'll go out of business or something like that. I mean, given how much people like to overeat, smoke too much, not exercise, drive too quickly, the drug companies will never go out of business. But this question came up, might there be a non-drug therapy, you know, like opening the veins to the brain as a way of treating MS? And the National MS Society, as well as other international MS societies, put forth millions and millions of dollars to study this in a very organized way. And so far, there really has been no convincing system-wide evidence that this really has helped. There have been several fatalities from this. You know, I realize in certain areas it's still controversial, and certainly everyone in this room wishes we could find something that would be such a quick treatment that would alleviate the terrible aspects of multiple sclerosis, but I think it's important to take a look at the different treatments that are being mentioned and really whether or not there's any science behind them, not just how much as to echo what Dr. Rubin said, I mean, there are lots of treatments going on. There's several ongoing trials, including from sites such as ours, and I think Dr. Rubin, Dr. Hintati's site, even in secondary progressive MS, there are more than a dozen trials we have going on in relapsing or remitting MS, both oral medications and others. Lemtrada, like Dr. Rubin mentioned, we've been using for 10.5 years here in our center. There are drugs for treating the symptoms of MS, spasticity, new treatments for spasticity, which may be superior to previous ones, drugs to help people walk, drugs to help people's mood. There's an ongoing trial which will report out in about 1.5 months in treating pain specifically in multiple sclerosis. So again, there are areas that clearly are very promising. There's a lot of science behind. I personally encourage people taking some of these other treatments and holding them with a grain of skepticism. I promise you the studies that we do with certain of the treatments, I hold a little bit of skepticism, but I want to know a way it works. Bottom line, blockages to the brain of veins that occurs in many other neurologic diseases, but those people don't have multiple sclerosis. Opening the veins, certainly there's a great interest in this. This was based upon a small report out of Italy many years ago that led to these large international trials of CCSVI to see if it would be effective. It turns out from these more recent trials to not be effective. An example of this in a different disease state, several years ago there was a report in Germany of the use of lithium for treating Lou Gehrig's disease. In the study of Lou Gehrig's disease, a disease which is common as MS, but people in that disease typically die within a few years, the people who received lithium in the German study, most of them survived who got lithium. This launched 3 large international trials of lithium involving thousands and thousands of patients. Unfortunately, as it turned out, in the lithium trial in Lou Gehrig's disease, actually more people died who got lithium despite the early promising results. So CCSVI, the early reports of Italy, were very promising. The follow-up has not been, and I think that's been the history of MS. Some treatments we've looked at in the past were very, very exciting. Some panned out, some didn't. And we want to really, place our marker on the area we think it's going to make a difference. And I'm glad that the MS Society has been one of the areas which has been really strong in helping support research in these non-drug treatments for MS as well.
Thank you. I have to support your discussion about the National MS Society being very active and proactive. I know that as a member of the board of directors for the Northern Illinois chapter, we have discussions about research and research trials and ways to gather funds for research money, and then when we have it, what do we do with it and how do we try to fairly allocate it? And believe me, it's not just a matter of what study sounds good or what looks like it might be beneficial for the most people. There are teams of researchers and clinicians and scholars who review every one of the applications for funding from the National MS Society for Research. They go through a various rigorous evaluation process, and what that tells me is that the research that is getting funded, particularly through the NMSS and collaboratively with other groups like the National Institutes of Health, is really very high quality research. Ideally, we'd like positive results from those studies. That it doesn't always pan out, but that doesn't mean the money was not well spent. It helps us identify some things that perhaps aren't as effective as we might have thought about to begin with. So a very positive approach to research in my mind. Dr. Goldman, another question, perhaps coming from some of us who don't have MS but who are aging. How can you strengthen the hippocampus?
So that's a topic that's actually been quite hot over the last decade, since the modulation of hippocampal neurogenesis had been found possible in animal models. And we have to realize that there's still not a lot known about the human hippocampus in terms of the turnover of neurons within it. There have only a couple studies that have been published over the years because it's awfully hard to work with the normal healthy adult hippocampus. And we can't be killing people along the way as test subjects, and so and there aren't any good ways to image the hippocampus with the degree of the cellular resolution required. So all that is by way of a caveat up front that the decade plus of research into animal models does not necessarily predict anything in humans. We just don't know. All that said, there is a substantial body of literature on how to modify hippocampal neurogenesis and functional outcomes in animals. And lots of drugs have been found that upregulate or downregulate hippocampal neurogenesis that can improve or, as the case may be, deteriorate memory. The strongest evidence by far is that exercise is the strongest long-term modulator of hippocampal neurogenesis, and there's a lot of debate why that is, how much of it is from the improvement in vascular health versus how much of it is because of the transient hypoxia that exercise can induce, which then induces new blood vessel formation, and then it turns out that the new neurons in the hippocampus are being generated in co-association with new blood vessels in the hippocampus. So one way or the other, exercise and vascular health appear to be by far the strongest associated factors with hippocampal health, with hippocampal neurogenesis, and with memory. And so, to the extent that you can, there's nothing better than just a lot of exercise.
Great, thank you. Now, a question, excuse me, for Dr. McCoy, and I know he and I have chatted about this in the clinic on a couple of occasions. Can a spinal tap with 6 oligoclonal bands present be negative for MS if you have bacterial overgrowth in your body? When and why do I need a spinal tap?
So I think the better part of the question is there at the end about when is a spinal tap necessary. Multiple sclerosis is now and always has been a clinical diagnosis. The most important thing is the story. Why are you here? Why did you come in? What symptoms do you have? What do we find on the physical examination? We take a look at your eyes, we watch the way you walk, we check your reflexes. That has been the bedrock of the diagnosis since Charcot described this disease in the 1800s. It was true with the Allison and Miller criteria, the Shoemaker criteria, the Poser criteria, the McDonald criteria. The story is the most important thing. With current medicine, we have a lot of other ancillary tools that are helpful. MRI is extremely helpful. Evoked potentials can be helpful. Spinal tap can be sometimes helpful. It is not absolutely necessary to have a spinal tap. Sometimes it can be helpful to differentiate certain diagnoses, but with our current criteria, we're not obligated to do a spinal tap. It depends a lot on the individual situation. No two people are exactly alike. So, do you have to have a spinal tap? No. If you had one, it was hopefully helpful for you and the physician to make the diagnosis, but it's not an absolutely critical step. The history and the physical are still the most important.
Thank you. Back down to Dr. Hentati. What are some of the treatments on the near horizon for progressive MS?
For progressive MS, there has been few trials that were done for the medication that are now used, for relapsing remitting MS, such as, interferon, glatiramer acetate. They were tried in the past, and basically interferon seemed that it helped, but it turned out that the patient have relapses, and then so they turned out that they are not effective. Lamtrada was tried, short, small group of patients, and did not seem to be reducing the progression of the disease. Unfortunately, there is no drug yet today that have shown to stop the progressive part of MS. There are a couple of trials. There is one trial that we are soon starting. It's a medication that is derived from FTY, which similar to fingolimod mechanism of action, which will hope that the effect of this medication that is not an anti-inflammatory effect will affect the progressive part of the disease. You know that it's very hard to treat a condition that we don't know the mechanism of it. So we don't know why these axons or neurons start degenerating on their own. And as Dr. Goodman said, that there is a controversy whether these are the axons that are not healthy, dying, or there is more inflammation in the brain, small that we don't see, that is killing the neurons. So as long as we don't know exactly what's going on, it's going to be very difficult to target this unknown by medication. So, but you know, there will be a lot of, I'm sure that the focus now for all drug companies will be progressive MS, because there is so many drugs for relapsing remitting MS that we probably can, we can find the drug that is effective to stop the relapsing remitting MS.
Thank you. I'm going to bounce back to Dr. Goldman because we have a plethora of questions here for you. Worsening demyelination and or remyelination in the brain is what you've talked about. What can you tell us about this remyelination process for people with primarily spinal cord disease?
So we don't actually know that the processes will be any different. We're setting up the initial trial focusing on brain because we're trying to really have a very sensitive array of tests, a test battery that will cover lots of potential modalities, lots of potential endpoints. And so neuropsychology, neurophysiology, neuroradiology will all be brought to bear, but we're really stressing the cognitive endpoints and the neuropsychologic endpoints that may be the most sensitive of all in terms of defining whether or not we have a technique that's efficacious, that works. With spinal cord, whether it's in the setting of neuromyelitis optica or transverse myelitis or just incidental lesions in a broader MS case, the strategy should be the same. If anything, we would expect it in some ways to be more straightforward. But for this first clinical trial, we're focusing on the brain because we want to have more sensitive indicators of efficacy, of whether this works, than we can obtain in the spinal cord. In the spinal cord, we would have, of course, motor output, motor outcome measures, and some neurophysiologic measures available, but that's it. Some neurourologic measures as well, but they're relatively limited in terms of their sensitivity for whether or not subtle degrees of improvement may be occurring. And so that's why for this first trial we're going with brain. Fundamentally, this should work every bit as well, if not better, for spinal cord. And I should say this is a debate we had very, very actively in our group, whether to focus on brain or spinal cord up front, and it was not much more informed than a flip of a coin in the final analysis. So we went with the brain really because the measures of efficacy are somewhat more sensitive than we would expect them to be in the spinal cord. But it should work in spinal cord as well.
Thank you. Dr. Bernard, there's been discussion about using toxins to induce animal models of MS. And the question is, could a toxin be causing demyelination in people with MS?
Well, I think that we could probably spend a lot of time on this question. That, MS is a nature-nurture question, and the toxin, I guess, would fit into the nurture or environmental component as to why some people develop MS. I think there have been a lot of potential candidates suggested, but I don't think that there's any one that we could really can suggest that you should avoid other than the usual things that are bad for the nervous system. I think that I don't really have a specific answer to any particular toxin. We know that the nervous system, in particular the developing nervous system, can be affected by things like lead in the drinking water. And if any of you are living in Chicago near where pipes are being changed right now, it might not be a bad idea to check your lead levels. But I think that any of the usual suspects are important for any nervous system, and in particular the developing nervous system. Was there any more specific?
No, that was it.
Smoking, of course, now is, I guess you could consider it, smoking is a kind of a toxin that's we didn't used to have this data. Now we can tell you that there is data that tells us that smoking is certainly not good for the nervous system, and in particular for MS. So that's one in particular that you can remove from your environmental exposures.
Thank you. Dr. Rubin, how far apart should a person with MS space the flu shot, shingles shot, and pneumonia shots?
Yeah, the short answer is I don't know. We do encourage patients, as was mentioned actually earlier, to actually get their vaccines, because obviously getting these disorders can have more significant consequences for the patients than getting the shots. And so we do encourage people to get these vaccines and keep up to date with all of their vaccinations. There's no specific time frame in terms of separating them out. In fact, some people actually can get them at the same time. They can go to, and get their flu and their shingles vaccine at the same time. And to my knowledge, there's no particular risk. If you're sensitive to vaccines or tend to react to them, you may want to space them out, but there's no specific recommendations in terms of when to, how much time, or whether there's even a need for a lot of time between them.
Great, thank you. Dr. Nguyen, can you comment on dosing of vitamin D?
There's increasing evidence that there are more people who may be vitamin D deficient. Most vitamins we get from our food, the vitamin A, the different B vitamins, vitamin C, vitamin E. The only food that's naturally rich in vitamin D really is egg yolk. Grains and cereal, milk have been enriched in vitamin D since World War II, but the primary source our body gets vitamin D from is the sun. As most of you know, over the last 100 years, since I've been starting practicing, society has moved indoors, and so we get less sunlight. Many of your physicians perhaps have measured vitamin D levels and recommended increasing source of vitamin D. Most people, I encourage people to take a once-a-day multiple vitamin, which has a vitamin D in it. Some people whose vitamin D is less than 20, clearly deficient, their physician will give them an additional, let's say 50,000 units of vitamin D once a week for a month, or a low amount of vitamin D, 1,000, 2,000 units on a more frequent basis for an ongoing period of time. Partly it's a function of what other conditions are. I simply warn people regarding taking excess vitamin D and calcium supplementation at the same time, particularly if one is susceptible to urinary tract infections. It may increase the risk of getting infected kidney stones, which can have bad consequences. Not all vitamins are necessarily beneficial, and I think just have to be careful in that regard. So for each individual person, I recommend simply talking this to your individual healthcare provider, your doctor, or your MS nurse.
Great, thank you. And we have time for one more question, and that is, we'll give this to Dr. McCoy. Can you accumulate brain lesions from head trauma like concussion or a history of high cholesterol?
So there's no clear association between trauma and multiple sclerosis. There was some controversy in the past. The data has been pretty clear that trauma itself does not appear to cause or worsen multiple sclerosis in the sense that it may cause a relapse. As you know, we're getting a great deal of data currently on concussion, particularly in athletes, be it football players, soccer, et cetera. I will say that a lot of the concussion data right now is very much emerging. It's a very controversial area. In terms of things like overall risk factors for brain health, high cholesterol, smoking, as was mentioned, high blood pressure are really critical factors. If everyone in the United States dropped their blood pressure by a few points, and if we all lost a little bit of weight, we would probably save our national health care overall. So high cholesterol, high blood pressure, smoking are things that are bad for your brain. Trauma is inevitably probably not good for your brain, but it's not associated with the cause or worsening of multiple sclerosis.
Thank you so much. And thank you to all of our panel members and Dr. Goldman as well.